Early childhood development is a multidimensional concept, which means different things for different people. From Thrive's perspective, we want to look at it holistically, ages from conception to age 8. We focus on health, nutrition, early learning, responsive caregiving, and child safety and security as drivers in the child development process. In terms of outcomes, we look at things like health, nutrition, cognition, and socio-emotional development.
We know that early childhood interventions can be very effective and have persistent, large effects on a multitude of outcomes. What we don't know is how to adapt these models to be able to implement them at scale within the tough constraints of the poorer countries.
Scale-up by itself is a science. It must be planned. We must look at the factors that enable it and how do we give it the best possible chance of success. We have to influence policy, and policy thrives on evidence. And I believe that's the gap that Thrive will be able to fill. Where there is anecdotal evidence, it's an opportunity to test it and be able to provide policymakers with the information that allows them to confidently make policy choices, and in particular invest the limited resources that the country has, because they know that this is backed by science, this is backed by evidence.
To find out more or support this project, get in touch.
Hello everyone, and welcome. I'm Susan Walker, a professor at the University of the West Indies in Jamaica, and also one of the Thrive research directors. I hope that short video was helpful in letting you learn a bit about our work. Thrive is a multi-country research program, and we focus on scaling early childhood development services in low and middle income countries, with a focus on 5 countries: Bangladesh, Ghana, Sierra Leone, Tanzania, and Kiribati. Thrive is funded by FCDO, the UK's Foreign, Commonwealth and Development Office, and our work in Kiribati is funded by MFAT, New Zealand's Ministry of Foreign Affairs and Trade. Thank you for joining the second session of our Thrive in Conversation series. As you heard in the video, we still face major gaps in our understanding of how to move from successful interventions into national systems in ways that are effective and sustainable. One important way to bridge these gaps is to strengthen dialogue, making sure that researchers and policymakers talk to and learn from each other, so that researchers ask the right questions and policymakers are able to make decisions that are grounded in evidence about what works at scale. Our new webinar series aims to support these needed conversations. Each month, the Thrive in Conversation webinars, we will look at ECD programs that are at different points on the scaling pathway, moving from identifying and understanding critical issues in child development, designing interventions and testing their feasibility and impact, testing at larger scale, integrating with national systems, and finally, continued evaluation of programs and adjustment. We invite a researcher or research team and a policymaker or practitioner to discuss the lessons learned and the challenges faced as programs move along this scaling journey. Today's webinar features a study implemented in Bangladesh that builds on a successful intervention at small scale and takes the initial steps of understanding how it can be delivered through a government system. The RINEW-G study set out to examine the feasibility of delivering a multi-component intervention through the health service. So today we'll discuss the challenges and lessons from this study that deepen our understanding of the process of transitioning to a wider scale through government systems. We're very pleased to be joined by Dr. Famida Tufail, distinguished scientist and senior consultant physician at ICDDRB, Dr. Jasmine Sultana, assistant scientist in the Environmental Health and WASH Research Group, also at ICDDRB, and Dr. Helen Pitchick, postdoctoral scholar at the Division of Epidemiology at the University of California, Berkeley School of Public Health. Welcome to you all, and thank you for joining us. We're also joined by Dr. Jahangir Rashid, who is currently Director of Finance Management at the Directorate of General of Education in the Ministry of Health and Family Welfare. At the time of the RINEW-G study, Dr. Rashid was Deputy Director in the Directorate of Health Services in the Ministry of Health and Family Welfare. Hello, Dr. Rashid. We'll begin with a 15-minute presentation about the RINEW-G study, and then move into our conversation, which is the core of the webinar series. Following that, we'll have some time for questions, and we'd very much like you all to be involved. So I'll now hand over to Helen and Jasmine for their presentation. And remember, you've got 15 minutes.
Hi, everyone. Thank you to Thrive for hosting us and Sue for the introduction. We're excited about the opportunity to share our work. I'm Helen, and I'll be joined by my colleague, Dr. Jasmine Sultana, during the presentation, and later by colleagues, Dr. Famia Tofal and Dr. Jahangir Rashid, for a conversation on learnings from this work. We'll be presenting our work to design and evaluate a multi-component child development intervention delivered to the government health system in Bangladesh. There are two main motivations for this work. The first is that children in many low-resource global settings live in environments with many direct and indirect risk factors for poor early child development. The nurturing care framework on the right, which is familiar to many of you, highlights some of these key groups of risk factors for diverting children off of their developmental trajectory. Within each of these, there are many individual exposures that can contribute. For example, within good health, that could include poor sanitation, poor air quality or heat, or exposure to environmental toxins. The second fact that motivated this work is that, as most of us know, small and medium scale responsive stimulation and nutrition interventions can improve early child development interventions. But these typically include only 3 components of the nurturing care framework, as highlighted on the right. Our research group was motivated to understand what about interventions that include multiple other components. Are these also effective, and could they possibly improve the environment in a more holistic way? So to answer this question, we designed a multi-component early child development intervention that included not only contents on early stimulation, responsive caregiving, and maternal and child nutrition, but also water, sanitation and hygiene, lead consumption prevention, and maternal mental health. We evaluated this intervention through a randomized control trial implemented in rural central Bangladesh and had scale in mind right from the beginning. We initially designed a group-based delivery in a pilot RCT and wanted to understand how that worked before we moved to the next step of scale. Now, this small-scale delivery improved multiple risk factors for early child development, not only early stimulation and responsive caregiving in addition to child development outcomes, but also maternal and child nutrition wasn't changed by the intervention, but we did find changes in water, sanitation and hygiene, lead consumption prevention, and maternal mental health. So we were thrilled by these results. We were excited about this evidence and knew that the intervention worked when delivered on a small scale, but there were multiple components of this work that wouldn't be feasible at scale as we delivered it in the pilot. For example, sessions were delivered by community members who were hired specifically to deliver the intervention, and they only delivered one group every 2 weeks. The sessions were delivered in the community courtyards, so right next to participants' homes, and participants were contacted individually prior to each session to encourage attendance. In addition, only some villages in a region were included, so it wasn't kind of a scaled up version by any means. This motivated the next step of the project was to examine the feasibility and effectiveness of implementing the multi-component intervention through the government health system itself. In this scaled up version, government health workers delivered the intervention at community healthcare centers, and eligible participants were initially notified of sessions, but weren't reminded individually to attend. And then we delivered the intervention throughout an entire subdistrict district, which Jasmine will tell us a little bit more about.
So now let's look at where the intervention was provided and how the intervention was provided. So you can see in the right-hand side, the map of Bangladesh with red highlight, that's Pabna district. And near to that, the dotted area, that's the Chatmohar subdistrict from where the intervention was provided. And each dot represents each healthcare facility from where the intervention was provided. And in this small area, there were around more than 25 to 50 villages and more than population size of 300,000. So you can imagine how overloaded the health workers from only 45 community healthcare facilities to deliver services to the community. So to meticulously design our intervention so that we can reach the population with only limited number of providers, what we did, we included the health ministry and the community-based healthcare services from the beginning of our intervention planning. After planning, we also finalized the implementation plan with the frontline health workers of this community so that they feel confident to provide these intervention services to the community. Next, please. So to give you an overview of the Bangladesh health system, you can see in the Ministry of Health and Family Welfare, there are two major wings. One is health and one is family planning. And in these two wings, there are different level of services that are provided from different level of facilities. And in the green ones, we selected the healthcare provider to provide the intervention services. Now let's look at from where the intervention were provided. Next. So in these red highlighted ones, the interventions were provided by the healthcare providers that we selected for the service provision of this multi-component intervention. Next, please. So this intervention that we piloted was really heavy in content. So it needs some modifications to go through the health system. And for this, some adaptations that we want to mention is that we made the intervention package 12-month duration to match with the yearly routine curriculum of the government health workers. We also separated pregnant women session from mother baby session so that the pregnant women do not need to wait for too long in a session to hear about the recommendation for them. Also, to reduce the workload of the health worker, what we did, we made the alternate session a reminder session to reinforce the behavioral recommendations so that they can practice more. The pregnant women in Bangladesh actually receive iron and folic acid routinely from the healthcare facilities. So we didn't add additional micronutrient delivery for the pregnant women in this multi-component intervention package. Also, what we did some additional integration of the components to reduce unique number of behavioral recommendations for the health workers. For example, we included hand washing and interaction during feeding the child with the complementary feeding recommendations so that in one recommendation they can include all, they don't need to talk about separately. So after planning all this, our target was to deliver the intervention 12 months. But unfortunately, due to COVID, we have to stop the intervention after 8 months. And in this 8-month intervention package, 71 government health workers were trained. Each actually have 10 to 15 groups to conduct these sessions in every 2 weeks. And as is shown in the map, the population size, the community census also shows that for this multi-component intervention in the Chatmohar subdistrict, there are more than 7,700 pregnant women and mothers who are eligible for this intervention package. So it was a huge workload for the government healthcare provider to provide. Next, please. So how we trained the healthcare worker with this huge number of packages of the intervention. We tried to make it in a progressive training modality so that each time they receive a minimum number of recommendations, minimum number of training for the recommendations, and each phase included theoretical and practical components, so they can learn the topic, they can practice the topic, and they can raise any issues and resolve with the trainers any issues they will face during training facilitation and during delivery of the intervention package in the community. Next, please. So these are some sample pictures of the intervention component, the materials that we provided for the child stimulation. You can see these are the pictures we provided to the mothers while conducting the sessions. Next, please.
Thanks, Jasmine. So I'll share a little bit about our results. We evaluated the impact of the RINEW-G intervention on the caregiving environment, caregiver mental health, and caregiver knowledge. We had initially planned to also measure child development, but as Jasmine mentioned, the timing of the COVID pandemic meant that we had to stop the intervention early, and we actually weren't able to do in-person assessments during the intervention end line. In terms of implementation, we found that 72% of scheduled sessions were conducted. And for attendance, we found that over half of the eligible participants attended at least one session, which we were very excited by. As this intervention was not, as I said, promoted individually to all individuals for each session. It was just promoted once in the community and kind of offered as a community resource. In terms of the quantitative results on the outcomes, we found that compared to children that attended 0 or only 1 session, those that attended 2 or more sessions had more play materials and child's books in the homes, and their caregivers knew more about lead. There were no differences in play activities, caregiver mental health, or maternal nutrition knowledge. There was an indication for dose response for play activities, with more sessions meaning more play activities. And since the initial results of this work, our team has been working to understand what's next, how can we further use these data and understand more about what went on and how to improve. And we've put together a couple key areas for next steps. The first key area revolves around access to sessions. So while we were encouraged by the initial turnout, as I mentioned, with so little community promotion, we wanted to understand who was attending and who wasn't. So you can see even within the group of folks who attended 1 or more sessions, there's lots of heterogeneity in how many sessions were attended. So one of the things we thought about was possibly distance to session location, which we did have data on, and we found that more than half of participants were within 1 kilometer of session locations, though many people were much further than that. So we hypothesized this may be one of the reasons, and we're doing ongoing analysis to examine this as well as other factors, including women's empowerment and other socio-demographic factors to understand what was associated with session attendance. Another ongoing question is how to improve delivery quality. So alongside our quantitative evaluation, we conducted a qualitative evaluation with key informant interviews with health workers and supervisors to better understand implementation, facilitators, and barriers. So we found several open questions, some of which will be discussed in the discussion today, most likely. So one challenge we know that is not unique to our intervention is high workload and low motivation and engagement for frontline health workers who have lots of other duties on their minds. One of the solutions we found that could be helpful is to give meaningful, if not non-monetary rewards for engagement with the sessions by health workers. Another challenge that's perhaps more unique to our intervention was we had a few challenges around toy storage and logistics, and we thought that, like other similar interventions, we could possibly try to make toys at home or have a toy library to reduce this burden. And the final one I'll mention here, you may have had on your mind since Jasmine showed the complex government health system delivering health services in Bangladesh, which was there are 2 different divisions that are operating these services. And so ownership of the program with our intervention was not clear between these 2 government systems. So in the future, we would have more clear ownership and supervision structure and responsibilities. So as a summary, we successfully had demonstrated feasibility of scaling up within the government system with over half of eligible participants attending at least 1 session. We also found increases in books, play materials, and knowledge of lead amongst those that did attend intervention sessions, but we have more work necessary to understand the reasons for lack of access to everyone, workload and healthcare workers, and session quality. And hopefully our discussion will be enlightening on those factors. Thanks so much to our study team, funders, and participants, and I'm looking forward to the discussion.
Thank you very much, Jasmine and Helen, for the clear presentation of the study findings and implications. If anyone would like to read more about the RINEW-G study, you can find links in the chat. So I'll now invite Dr. Rashid to join Famida and Jasmine in a conversation about what these research findings mean for the scaling of ECD services in Bangladesh. Before we start the conversation, I'd just like to ask Dr. Rashid to briefly describe your role in the Ministry of Health during the RINEW-G study and your experience of working with the research team. What were the things that made the collaboration successful?
Nice to be here in this conversation. Regarding my involvement in RINEW-G project at that time, I was working as a Deputy Director and Program Manager of Community-Based Healthcare and one of the operational plan of government health services. And my responsibility was human resource development and community mobilization of community clinic by trained sub-district level manager known as Upajala Health and Family Planning Officer and health worker like health assistant, family welfare assistant, CHCP, community health care provider. And in each community clinic, there is a community group and 3 community support group. So we have also trained them. And in community group, there is also participant from local government, in fact. So my main role was to train them and for betterment of the community clinic more functioning. And while working on this project, some of the factors that help us succeed were early communication, regular update sharing, like frequent field visit and monitoring, and also co-creating solution to challenges like space arrangement in community clinic, hygiene management during session, time allocation of session for session, and toys distribution, etc. Thank you.
Thanks, Dr. Okay, thanks, Dr. Rashid, and for highlighting the importance of communication and also the co-creation of solutions, which are so important. Yeah. So turning to you now, Famida, the RINEW-G study is at the critical juncture of moving from highly supported and controlled interventions to beginning to see how the intervention might be delivered through a government system. The program was delivered by existing staff in the health centers. Would you tell us a little bit about how this went and what were some of the successes and challenges?
Thank you, Sue. As demonstrated in the presentation, our major accomplishments or successes centered on establishing the feasibility of delivering a multi-component intervention to pregnant women and mother-child dietes within the community, utilizing both community clinics and family welfare centers. Our major accomplishments or successes include, firstly, the successful training of providers and the effective delivery of the intervention. Secondly, this intervention included all children in the community who are eligible, not restricted to vulnerable groups, or promotion of the intervention was designed to be scalable. Thirdly, over half of the eligible community members attended at least one session, which we see as a success for this level of promotion. Nevertheless, several challenges were encountered during this implementation. Our major challenges with delivery were training of health workers, the volume and the complexity of the intervention with 24 sessions were challenging for health workers to learn at a time and competently deliver this newly learned information. Secondly, alignment with existing workloads of health workers, incorporating the additional responsibilities associated with session delivery was difficult, given that the healthcare workers already had substantial routine workloads. Thirdly, logistics supplies and storage. It was challenging to maintain a consistent supply of toys and books to the community clinics, alongside securing adequate storage for those materials until delivery. And lastly, space management for session delivery. Limited physical spaces within two-roomed community clinics created constraints in some cases for conducting the intervention sessions effectively. So those were our challenges.
So a mixture of success. I mean, really important that you demonstrated the feasibility, but also several challenges. So following on from that, it would be great to hear about some of the strategies you developed to support the health workforce in delivering the program, and any other strategies you think might be useful for future implementation.
Thank you. Strategies to mitigate challenges include, for the first problem, like training of health workers, we arranged progressive training that you have seen in the presentation, which allowed us to focus on only a subset of sessions. So like out of 24 sessions, 8 sessions at a time. This helped to reduce the training content and focus more on learning and practicing. Secondly, to align with existing workload, we made sessions flexible to deliver as per the convenience of health workers' time availability. And other strategies we were thinking for future is merging the session with routine awareness sessions of health worker that starts in the morning of more, and also to make the sessions more structured with the toy materials instead of multiple toy, like make a single toy like doll day, ball day, or like puzzle day, so that they don't need to struggle with searching the toys for each session, several toys. The RINEW intervention had multiple components we tried to make it easier to deliver, and we integrated messages and used technologies like tablet-based app to guide selection of session contents. Our future suggestion, like we could make more video guided sessions that will be easier for this problem. Our other problem was logistics supply and storage area. Phase-wise logistic distribution was organized to ensure smooth implementation. Age-specific toys and materials required for each sessions were pre-packed and arranged clearly in clearly labeled boxes, facilitating easy access, timely distribution, and efficient session delivery. But making and managing all these toys and all the eligible participants require time and meticulous planning and management. So our future suggestion, homemade toys model that already Jasmine presented in her presentation, showed in the presentation, distribution of storage container and minimal toy distribution we are thinking as another options, like making the some of the things that we distribute can restrict it to only book and blocks. For space management, at the beginning, we had a larger group size. It was not restricted, and there were more mothers in the first session, which was difficult to manage. So our suggestion was to keep group size strictly not exceeding 10 to 15 mothers. And we, in future suggestion, we think that our group size cap can be 15 and arrange additional sitting facility in the community clinic. And another option we were also thinking about, arrange some sessions in the courtyard in the community by secondary or backup providers, those are family welfare assistant and health assistants.
Great, thank you. So Dr. Rashid, Famida mentioned a number of strategies, for example, how to align with staff workload and managing space constraints. Would you comment on their feasibility and which might be the most promising to implement?
Regarding training of healthcare worker, as Famida said, cascade model training was already existing at that time for community clinic, where ex-government health professional were the master trainer, and the training logistics support was provided by the community healthcare program. So in future, depending on the government setup, either ex or existing government health professional can act as a master trainer for this type of activities. Regarding aligning with existing workload, I think it is possible to merge this type of session with the routine awareness session of the community clinic during morning session. And regarding logistic storage area, yes, we have some newly designed community clinic that has more space, like 4 room in fact. So logistic storage space can be designed as per requirement. But our old community clinic were only 2 room. So this might be the challenging. The other option recommended by Dr. Famida, such as minimal toy distribution and homemade toy model, can be tried in this case. And regarding space management for session conduction, as I already mentioned, the newly designed community clinic has more space, but it will be difficult in case of old community. So suggestion from Ida that such shift arrangement for session conduction can be tried, considering the workload in the field of the FWA, family welfare assistant and health assistant. Regular courtyard session conduction can be challenging for them.
Okay, so thanks so much for the suggestions around how a program like RINEW-G can be managed and integrated within the system constraints that are bound to exist.
Right.
So I just want with you to move on to another critical issue. So as was mentioned in the presentation, all mothers in the sub-district with children less than 12 months were invited to participate, and about half of the mothers attended at least one session. And for those who attended more than one, most attended about 4 sessions. So what were some of the things that may have encouraged or discouraged mothers from attending? And how is your greater understanding of this now helping you to consider ways to increase reach and also sustain engagement?
Thank you, Susan, for raising this important issue of attendance for this type of scaling up in a program of multi-component intervention. So from our perspective, what we learned, there are multiple facilitators that affected the attendance in our community. So first of all, I'd like to mention that in the first touch, when the community health workers invited the mothers, they provided a pictorial health card to all the mothers with some of the behavioral recommendations. So I think that one of the facilitators that encouraged the mother to learn more about what will be happening in these sessions. And then the child stimulation, playing with children, interacting with children, that was a very new topic for the mother. It was not discussed earlier or shared in any other media earlier to the rural pregnant women or mother with young children that you have to play with them. That was kind of another facilitator of encouraging the mother to learn more. What is this about? And another facilitator is when some of the mothers attended the session. You mentioned we already shown that more than 50% attended at least one of the session. So when they came, some of them actually received some toys, some color books, some micronutrient for the children. And these logistics might have acted as a facilitator also to attend, to come to future sessions, to receive some of the materials they received and use that materials and play with their children. And another facilitator, as we already Helen showed, sorry, my camera is acting weird again.
No problem.
Can you hear
Let's
me?
continue.
Okay. So I think another facilitator was the distance. So the household, those were closer to the community clinic, actually attended more compared to those who were distant from the community clinic or the healthcare facility where the sessions were provided. So these are some of the facilitators that we think from our data that these are acting as a facilitator to increase the session attendance. And regarding some barriers, so the mothers, we have shown that the attrition was low. So the some of the mothers who came, they didn't continue to come. So what major thing we find is the distance from the healthcare facility. So around half of the participants were living more than 1 kilometer from from the nearest healthcare facility. So that might act as a barrier for the mother and the pregnant women to travel a long time and come to the facility to attend the sessions. Another one is the motivation for the mother. So we only reach the mother once. So what that happened is that only one time touch to ask them to come to the session might not be enough. We might try next time some other strategies to inform and motivate the mother to come out. So the family motivation is really important to bring the mothers for this type of activities, because they have other works to do. They have other family members, other decision makers in their family. If the family is not motivated, if the family is not supportive for the mother to attend this type of session, this is really difficult for the mother to continue. So along this slide, what we have learned, there are a couple of suggestions we have regarding distance. What we in future we can try is that how we can reach these mothers who are living distance with some of the messages. Can we integrate some of the messages with the other government or non-government program to reach the mother who are living distant from healthcare facilities? And how we can increase the awareness among the mothers, motivate the mothers? Can we, like as Dr. Rashid has already mentioned about community group and community support group who are involved with the community clinic, who are already the community members, elite, religious leaders or school teachers and adolescents who are involved in this community group and community support group, they usually have regular meetings. Can we encourage this community support group to remind the mothers about attending the sessions? Can this be done, and can this have an effect on that? Another one is you might have heard about the expanded program on immunization in Bangladesh. It is the successful immunization program globally. So the awareness program activities they take for rolling out new vaccine, they do like massive awareness sessions through mass media, print and electronic media, social media, and through other means. So for rolling up of like multi-component intervention, can we use some of this learning from the immunization program to raise awareness among the community or motivate the family members and mothers to attend this type of sessions? Can we do that? So these are some of the recommendations to try out in future.
Okay, thanks, Jasmine. There are really some interesting points around motivating and not just caregivers, but families and communities. Dr. Rashid, could you briefly, we're wanting to save some time for questions. So could you just briefly give some reflections on some of the things that Jasmine has suggested? And are there ways that the health system already encourages uptake that could be helpful?
Yeah, like as Jasmine says about distance from community clinic, I think integration of messages with other government system will require further discussion and exploration with respective ministries and departments. If the private sector and NGOs are motivated, they can integrate this type of program into their activities. And regarding single contact with the mother, I think it is possible for family welfare assistant and health assistant to provide reminder during their routine household visit or immunization activity. And I already said that there is around 50 to 60 member in community group and community support group. So if we can motivate them, they can carry on this message to the specific target people. And as Jasmine said, that mass media, involvement of mass media, electronic media, print and electronic media, nationwide awareness activities will require additional fund. So we have to think this in our mind.
Okay, thanks, Dr. Rashid. And so we'll move on to be moving on to Q&A, but before we do that, I'd just like each of you to give a very brief what your key takeaway or message from the study is. Famida, we'll start with you. Mike, you're muted.
Sorry. I think most of the challenges we face during RINEW-G might be addressed with increased awareness and understanding of the importance of early childhood development. So mass media and other awareness campaign worked in the past, such as for immunization, as Dr. Rashid mentioned, which can be replicated to raise awareness among caregivers as well as delivery agent and the family members. Thank you.
Okay. Dr. Rashid?
Yeah, it is feasible to train and deliver a multi-component early childhood development intervention through community clinic. There are some unanswered questions about session quality, access, and monitoring, but this work and other will help us to resolve this, I think.
And finally, Jasmine?
Thank you. So what we learned is that scaling is hard, and integration of like these many types of intervention into a multi-component intervention is really challenging. So in future, like incrementally, if we try and test some of the methods that we discuss, that might result in more feasible and scalable intervention to deliver through the health system and reach more mother and improve the cognitive development of the future children we'll have. Thank you.
Okay, so thank you all for the very informative conversation. And I especially liked Jasmine's takeaway with her reminder that scaling is hard and emphasizing the need for continued testing and adjusting to support scalability. So we'll now turn to some questions from the audience. There's a question on training, and I wondered, Hamida, if you could take that one. It's about, a little bit more about the training process, who did the training, what it involved, what were some of the key elements. Maybe you could talk just briefly about that.
Sure. Yeah, training, we had our trained psychologists who know the whole program. They trained to our health workers. And like as I mentioned, the training was long with 24 sessions. So we split it into smaller number of sessions. So at a time they can learn quickly and deliver it. It was phase-wise and like tablet-based also. Some of the things were instructed like they can automatically move forward for next activities set in the tablets. So this is the arrangement, and there were like periodic refresher trainings as well as meetings to handle all the problems or trouble they are facing to mitigate it accordingly. So we were ICDDRB trainer groups were there to train the government health workers. Anything I missed? Was there
no, I
anything
mean,
else?
and I just want, and so your plans going forward would be to, well, if you were continuing, what would be your plans for training? How you would adjust if you were no longer able to do the training through
Right.
from experts at ICDRB?
Right. We think that as Dr. Rashid also mentioned, the cascade model training. So we were thinking of training have master trainers from government sites. So Dr. Rashid shared that previously it worked in their other program. So if we can train the master trainers, so they can easily train their staff, and that will be embedded in the national health system. So it will be someone will be responsible, and from we can give technical supports to train the master trainers. That could be one model in future to move forward.
Yeah. I'm not sure who's the best person to answer this, but I'll offer it to Jasmine. Somebody's interested in what was the involvement of the local government system with the research, especially the Upazila member and the chairman. So what's their involvement of the local government?
So yes, thank you for the question. So the local government, what we did the community sensitization. We involved the local government regarding the program we will be implementing in each union. So we have union level local government. So we involve all of them. We inform them. We had stakeholder meetings with them, and we had a detailed discussion. The queries they raised during those discussion, we tried to resolve those, and based on their support, they supported throughout the program because it was a sub-district wise. So there are multiple unions, and we tried to address all the questions or all the issues they raise. And we also took suggestion during the sensitization meeting who to involve. We involved the community group and community support group, and if any other stakeholder we need to involve, we ask suggestions from them and we involve them accordingly. So they were involved in disseminating the information and also supporting this work in the field.
Okay, thanks very much. And then another question was, were there any findings specifically pertaining to caregivers of children living with disabilities? So I don't know whether that was something that you looked at within the study, Famida?
Yeah, like children with disability, we didn't specifically address for those issues, but they were also welcomed because we addressed all children. So not with major disability, some children with minor disability attended our sessions. So it was open to all. But we also felt the necessities to add something more in our intervention to address special need children if that can be managed.
Okay, and and then there's a question about how much the program addressed the involvement of both parents, given the traditional roles for child rearing and caring duties. Jasmine, would you like to speak about that? Whether you thought about how to involve both parents?
Yeah, so unfortunately, in this program, we didn't directly involve fathers, but what we did during our community sensitization meetings, we shared information with the community members about why the child development intervention, multi-component intervention is important, and what role also can the other family members can play, reminding mothers, supporting mothers. Unfortunately, we didn't involve any direct sessions were not conducted with the fathers, but fortunately in future, we would like to try this out in future.
Okay. And then a question about the design process. Perhaps that's for you, Famida. How much did you align the intervention with the current objectives of the local government? So we've spoken about the involvement of the local government in terms of raising awareness and raising the involvement of the community. But did you align in any other ways with the objectives of the local government?
like Bangladesh government actually released the ECD Act in 2013. So it is there as a government mandate, but local government, this is again we found that they are interested when they heard about this program, and all are concerned about their children. So they actually helped us in that regard. It was new to them, although it's in our mandate, but like it was new to them, and we try to. That's why we actually try to blend with their health system, where there are other components like nutrition component, immunization component, those components in the health system program. We try to integrate with our model with their program and what is already delivered, like nutrition mainstreaming system. So we didn't repeat those. The missing piece attached with child development activities, we try to blend and integrate those to go with their flow of activities. So this is how we actually try to blend with their existing program and fit our program with their existing work.
Okay. And then one more, maybe this one back to Jasmine. There are other campaigns that the government already does, and I think you touched on this, Famida, around the campaigns around promoting immunizations. And did you consider maybe linking with any of that, or what did you consider in terms of encouraging attendance?
Yes. So as we mentioned, as we mentioned earlier, we actually want to try in future if there is any scope based on the successful immunization program campaign, we can try this model and check, test if that model works for child development and multi-component intervention also.
Okay.
In addition, I also
Okay, go ahead.
Yeah.
Go ahead.
Yeah.
Go.
Yeah, in addition, I think lots of programs now, awareness is raised, like lots of programs, TB programs, different like Sisimpur, one of the child-focused program. So we had those programs. So we were also trying to communicate with them to blend our components important for children with their activities to being increase awareness among the community, TV and media.
Yeah. So just to wrap up with you, Dr. Rashid, linking back to what Sandra, Pamela, and Jasmine have just been saying, how feasible do you think it would be? I know you mentioned it would take resources to either link this early childhood stimulation or something like that with one of the campaigns, or what do you think about that?
Yeah, I think it is possible, always possible, but we have to be a motivated one, and government prefer scaling of all eligible children because all children deserve equal opportunity, and because children are the future of our nation. So I think if we can address this thing properly, I think government will come forward for scaling this type of program, in fact.
Okay. So thank you all for your input today, taking the time to be with us.